Because people who are homosexuals are marginalized. People who are bisexuals hide themselves. People who are prostitutes, drug addicts, or as Gentry refers to, the unchurched. Okay, the unchurched who engage in behavior that is unsanctioned, don't have a refuge and don't have a safe haven in the black community. Okay, a community who have traditionally provided hospice and benevolent services to. It's no understatement that stigma is a huge part of the pattern of marginalization of people who are unchurched and most likely to experience high rates of HIV/AIDS morbidity and mortality because of where they live, because of the exposure to violence, because of the exposure to poverty and drugs, and we need to realize that this is their network of sexual networks. Okay, this is where their partners come from. All right. We also, though, should realize that there are educated black women who are contracting HIV/AIDS. Okay, and it has a great deal to do with who they're connecting with, and you tend to connect with people from your community. Okay, people you may have known. Okay, people whose families you may have known. That's there. Also, when domestic violence enters the picture, you really are in trouble. Because not only did you sleep with this man, who's beating up on you, you have HIV/AIDS. What is your problem? What are you doing? And there's no sympathy for you there. The minister is not always there. The church deaconess ain't there. The trustee doesn't want to deal with you. Those missionaries who will go over to sub-Saharan Africa don't want to deal with you. Don't want to deal with you. So the community withdraws affirmation as ideological disavowal. Withdrawals. It's over. It's no secret, for example, that many people in the black community are very aware of this disease, but they are reluctant to aggressively assist in preventing the disease. So when HIV/AIDS is left untreated, then the black community becomes a way station for the cycle of HIV/AIDS contagion and or oppression, because it has not been ordained by the organic leadership. It's not been ordained by city councilmen. It's not been ordained by folk on the school board. It's not been ordained by Mama Jane, who is the grandmother who still wears the flowered nightgown in the neighborhood. Not been ordained by the numbers runner. Okay, it's not ordained by your medical doctor. It's not ordained by your beautician. I was in the beauty parlor, and I like to start controversial conversations to get a flavor for what people are saying out there. That's how you find out. And they were speaking about what was happening. A little girl was killed, and they were talking about that, and then they talked about some of the other things that were happening in the black community. And I said, yeah, what about HIV/AIDS? Whereas my grandma would say, it got so quiet you could hear a rat piss on cotton. Nobody said anything. They looked at me as if I'd said something about their mama. Nobody said anything. And that is typically the response that I get when I bring up HIV/AIDS. It's really sad. The other perception is that persons still view HIV/AIDS as a white male gay disease. As a white male gay disease. The other piece is that the black church is still somewhat influential as an enforcer of behavioral code. Okay, and so homosexuality again is apathetic and unacknowledged. Now, what is so weird about that is that most musicians, or perhaps a percentage, or you have other people who are active in church are gay. Okay, whatever, right? But we cannot get past that. And they have to feel some sense of marginality in church. They have to. They have to. Okay, all right. So, my argument is this. If churches have not been able to solve decades-old problems, teenage pregnancy, sexually transmitted diseases, family planning, okay, and other domestically violent related diseases or domestic diseases, we cannot look to church to be the center of the Renaissance movement for HIV/AIDS. So my first recommendation is that effective HIV/AIDS intervention with women, and in turn, when you assist women, family will be centered, should not be wholly centered within the church. Intervention must be effectively mediated through systems that openly acknowledge partnerships to fight the disease. So we're speaking about those agencies that may have developed HIV/AIDS programs, Clinics, okay, public health clinics, we need to really get in there much more. Peer mentoring associations, I work a great deal with the HIV/AIDS Resource Center on the campus of the Eastern Virginia Medical School. We need to get in there, who have a peer mentoring association that's very effective. We need to really look at how many specialty shelters we have for persons with HIV/AIDS. How many are there? Where are they? What do they need? And churches with effective HIV/AIDS ministries. We need to create an intersection and not just look to church to do this, that, and the other. Another example would be to co-op a program that I worked with, a research project called Bridges to the Community here in Philadelphia in the 90s. And it was a relapse recovery project where spiritual women who were either Muslim or Baptist or from other religious affiliations came together and were spiritual mentors to women who were about to be released from their recovery programs back into the community. But they were with a spiritual leader who walked with them, knowing that those women were going right back into the environments that they used in. And it proved to be effective. We need to perhaps duplicate that in some way. Another ideological barrier is the idea, as I mentioned before, that HIV/AIDS it promotes racial genocide. Okay, given the history of the deliberate healthcare industry's abuse of black women through experimentation, dissection of black bodies, misuse of organ donation and transplantation, and the culpability of the American Medical Association's role in NAPAS and universal health care, as documented most notably in Harriet Washington's textbook, Medical Apartheid, which I believe you should read, there is a distrust of the healthcare industry in our community. So conspiracy theory, we must address it, not address it cynically. All right. Kathy Cohen, socialist out of Chicago, pointed out that while media coverage gives voice to to other women, it tends not to give the same kind of voice to black women. I'm merging two together. So my second recommendation is to extend the Helping Network to the public media, to find innovative ways to engage in relentless public service announcements within the community, to make sure that black women are advertised, if you will, as family women, as strong women, but as women who are taking care of business at home and not just as the victims. And we must work with anchors and with news directors and producers because they decide what stories air on TV. My third recommendation is to extend the systems of generalist practice theory. We need to talk about our generalist practitioners also learning how to work with the public media. That should be a part, I argue, in generalist practice. And on the internet, because the internet is now a huge way in which messages are being advertised. Our students need to become sophisticated enough in addressing the news media and about the impact of HIV/AIDS on black women, by learning the roles of those in the media, and by teaching the media about social work values and ethics. Lastly, very quickly, the over-sensationalized men on the down low phenomenon, which means you know that men are engaged in a bisexual lifestyle, has garnered a great deal of attention, created a lot of misunderstanding, and all. More attention is really paid to the drama of it. Okay? But black women, you are at the center of this phenomena, okay? And we need to address the players, and we need to address how black women and children are affected, all right? So there needs to be a conversation, because I argue there's no demarcation between men on the down low and black women who get the disease, okay? If you get a disease, you have the disease. So given the intimacy and relationship issues that is exposed as a result of men on the down low, my fourth recommendation is that we reposition the dialogue about men on the down low, because we need to make sure it's open. We need to address the historic issues of relationship infidelity in America, okay, with regards to lying and cheating and selfishness and dishonesty. And we need to talk about homophobia, and we need to talk about bisexuality, and I believe that we need to argue that funding needs to be created for this kind of dialogue, which has healing properties. Lastly, black women are regarded as the bearers of remarkable courage and resilience. All right. Despite the inadequate distribution of resources, we face unique challenges in a racial structure, in the marketplace, a lack of power because of class and because of gender. Dr. Perry was right. And this has occurred historically. Even Phyllis Day, feminist scholar, has documented this. Well, we need to remember that, black women is the embodiment of spiritual strength. We're the embodiment of a very different kind of intangible strength. I argue that it is cultural, that it is historic. But there's also the stereotype of being a